Okay, welcome. Michelle, I think you are up.
All right. Well, welcome everybody on this beautiful June day during your lunch. Thanks for sharing with us today. So today we are presenting as part of the PQC Vermont, an update on the family care plan and CAPTA in Vermont. And I have Kayla Pinko and Katie Leffel here with me today, and I will let them introduce themselves. But I am Michelle Shepard. I am a pediatrician and I work as an advisor for ICONS in the PQC. Um, and Katie and Kayla, do you want to do a brief intro before we jump in?
Hi, I'm Katie Leffel. I'm a nurse at the Department of Health, focusing on maternal mortality and perinatal quality.
Good afternoon. My name is Kayla Pinko, and I am the AIM Alliance for Innovation on Maternal Health nurse educator with the PQC.
Excellent. All right. I think we can go to the next slide. All right. General housekeeping. Everyone knows that we love the chat here at VCHIP. So please use the chat if you need to ask a question during the meeting. You are muted when you are joined, but if we have time for a Q&A, we certainly want people to be able to unmute and talk with us directly. There are captions available, and you just need to navigate to show captioning. And then we do very much appreciate evaluations and any sort of feedback you can give us. It helps us to determine what to continue to focus on as we continue our quality improvement journey. Next slide. Acknowledgements. Let me know if people can hear weird sounds in my background because I think there's someone in the office next to me now. So this webinar is partially supported by HRSA and the Department of Health and Human Services as part of the Alliance for Innovation on Maternal Health, or AIM. And anything we present here are the view of us and don't represent any part of the government at all. Next slide. I'm getting some headphones. The rest of us have no disclosures. Next slide. All right, so my job here, first and foremost, is to set the stage so we all are on the same level when it comes to discussing CARA and CAPTA. Also are going to talk a little bit about just understanding the background of when these different pieces of legislation came into place and how Vermont handled these legislative challenges. We're going to talk about the family care plan, which used to be called the Plan of Safe Care. And we're going to talk a little bit about how we in Vermont have responded to these requirements for data reporting and notifications. Next slide, please. So the Child Abuse Prevention and Treatment Act is a huge body of legislation. And this came to be in 1974 and has been amended and updated and reauthorized a number of times since then. The highlights that I want to bring everyone's attention to is really in 2016, the CARA, or Comprehensive Addiction and Recovery Act, came online, and that really gave expectations for each state with 4 priorities: to identify infants affected by substance use during pregnancy, to notify the State Child Protective Services Organization, to develop a plan of safe care, and to submit annual data to the Children's Bureau. And we were one of the early states involved in different projects to launch plans of safe care. So we have been doing this since 2017. Our initial plan of safe care and CAPTA notification process came online. It was revised in 2021, and shortly thereafter, CAPTA was reauthorized in 2021 with a large update to both the language and what was included in that legislation. It was largely completely X'd out and redone. Now, CAPTA is not just the plan of safe care and CARA, it is much larger than that. And so in order for states to receive funding from the federal government to mitigate child abuse and neglect in all different forms, they need to be in compliance with CAPTA and CARA. Next slide, please. So I don't want to spend too much time talking about things other than just knowing that when the 2016 CARA Act came on, the goal was really to address safety needs with the development of a plan of safe care, really there to help support the infant and less impact and thought given to the family as a unit. Interestingly, each state was set out to define their own pathway to identify infants and do the notifications, and there was no template for the plan of safe care. The only requirement was that annual aggregate data to the Children's Bureau, and that the governor had to prove that your state was in compliance. So in Vermont, we went about this process of identification using informal policies. We did not write a law. There are many other states that do have laws around substance use during pregnancy. We defined the notification system separate from the pathway of reports, and this allows de-identified fax or emails if there are no safety concerns in place. That's different than a report, which is made if there are safety concerns regarding child abuse or neglect as they relate to substance use in pregnancy. We developed a plan of safe care, which was a paper form. Many of you have seen that form. It was completed at hospital discharge, and the goal was to share it with the infant's PCP. Data collection was used. A de-identified notification form used to be called the DCF notification, then the CAPTA notification, and we used that information to submit our annual data. Next slide. In 2021, the CAPTA reauthorization was a major overhaul of the legislation. This now changed the goal at the federal level to ensure the safety, permanency, and well-being of infants, and really supporting states in providing a public health response, and really looking at the family care plan and using that new language, no longer using plan of safe care, which was quite stigmatizing. So really thinking of it as a comprehensive tool to address the needs of infants, families, and their children. And so they also wanted to improve the capacity of personnel throughout the different states whose role was to develop, implement, and monitor family care plans. And very specifically called out exactly what we were already doing, which is development of a system of notifications that is distinct and separate from the system used for child abuse and neglect. So this was a big deal for the states that were doing this in a different way, right? So a lot of states were actually reporting all families using substances to their CPS agency and investigating or opening a assessment for all families. So what did we do? We were already doing this, but it came along right around at the right time. We adopted the family care plan language and convened a team, of which the three of us are part of that team, to revise a new family care plan to replace the old plan of safe care. We also transitioned the CAPTA notification and family care plan responsibilities away from the Department of Children and Family website and towards the Department of Health, which helps to reduce stigma and fear around families engaging in the process. We developed a new electronic family care plan template, which you will see as we move through today's talk, and initiating that in the prenatal space through referral to an engagement with nurse home visitors. We also tested, and are rolled out the electronic CAPTA notification. So this continues our established system that is separate from reporting safety concerns to DCF. So we're making our system better, but we were already well ahead of the curve when this came through. Next slide. So we had around the same time, some work with the in-depth technical assistance, which was provided by a very large body, the National Center of Substance Abuse and Child Welfare. This was really meant to look at how we were doing things around the state. And some of our goals of this work were to update our language, develop an online family care plan, the electronic CAPTA notifications, and really work on a family-centered website support material. And so all of these things we did through the IDTA work launched in 2025. Next slide. And I just wanted to show an example of the work that was done for the in-depth technical assistance and our work plan goals, and really looking at how how much substance use was involved in child welfare. And that looks at both during pregnancy and outside of pregnancy. But just that reminder of this is a big space for us to continue to work in. Next slide, please. And I'm
So,
going to turn it over. Yep.
I just would like to always set the stage for why we talk so much about perinatal substance use. I've had people ask, like, why are we focusing so much on that in Vermont? We have lots of issues to look at. And the reason why is that we really see substance use impacting our birthing population pretty heavily. When you receive these slides, these are links that you can look at. But the Maternal Mortality Review Panel has reviewed deaths over the last decade plus, and accidental overdose continues to be our leading cause of maternal death in Vermont with 48%. And we see substance use across those cases, even when it's not the cause of death, with suicide a close second there. And then the third bullet point is just about that need to connect people with services because we see most of the deaths happening in that postpartum period after they exit obstetrical care. So we really want to make sure they're connected well to community supports. At the bottom on the left, we had a study of qualitative study of birthing people with SUD in Vermont. And community and wraparound support was identified as a key piece of the supports identified by people with substance use who have given birth in the last 18 months or so. And the quote here was trusted case managers and peer support aid navigation of systems, empowering patients beyond substance use treatment. So really connecting those spaces for families. And on the right, this is just one piece of information from the PRAMS, which is a anonymous survey sent out to birthing people in the year after birth. And it just highlights that drinking alcohol continues to be our leading issue when it comes to substance use in pregnancy. And on the right-hand side, you see that that's 14% of people aged 35 plus and 9% of people aged 25 to 34 who have given birth in the last year reported drinking alcohol in their third trimester. So there are other substances being used in pregnancy for sure, but I think we just need to continue to focus on cannabis and alcohol as well as the other substances. Next slide, please. So as Michelle mentioned, we did a revision of the CAPTA process, made some changes around what gets submitted and how it's submitted. So it's been very successful. We started doing that in January of 2026 on the electronic platform. And you can see here the number of submissions for a total of 146 in this in the first 5 months of the year, with the number of birthing hospitals represented on the right. So we capture most of the hospitals have submitted, or all of the hospitals have submitted using this form, which has been great. It's been very successful. Next slide, please. And this is just a little bit of detail about what the data that we're seeing through this CAPTA form. So the purple box is the substances being reported as a percentage. So you see cannabis there as a pretty significant leader there with nicotine and MOUD and stimulants or cocaine and other stimulants reported as well. And then I think the other key piece here is at the bottom there, that's 48% of the reports are polysubstance use, which we see echoed in other sources of data as well. People are using multiple substances in pregnancy. And on the right, a little bit of a snapshot there, 35% of pregnant patients were engaged in services prior to delivery. The CAPTA doesn't capture detail about that, just that they are engaged in services. So we have a lot of work to do to connect people. We have a lot of area of growth there. 79% were insured by Medicaid for their birth, and 85% of patients did not have a DCF report indicated. So these are families where their main source of supports are going to be coming from referrals made in that obstetrical space and or in their pediatric office. So really emphasizing that the onus is on us as support providers, whether it's in the clinical spaces or the community spaces, to make sure families are getting offered resources. Next slide. So the CAPTA work that we're going to do continuing this year is we're just going to continue monitoring submissions. We're going to support whatever hospitals out there have questions continuing about adapting this process. And then we want to create more regular data reports that are accessible for people interested in understanding perinatal substance use in Vermont. Next slide. And this is Kayla.
So just like IDTA was a way to bring groups of people together to work on this work, through our AIM team, we have implemented the care of pregnant and postpartum people with substance use disorder, the patient safety bundle. So I just pulled out a couple of the highlights of what the recommendations are that relate back to this work on, they call it plan of safe care because that's the verbiage that was used when this bundle first was published. But think it really speaks to all the work that we're trying to do and the lens that we took in making some of these revisions. So making sure to establish specific prenatal, intrapartum, and postpartum care pathways that facilitate coordination among providers. And through that year that follows, as Katie referenced back to the MMRP data, like following through that whole year postpartum is really crucial for supporting our families. Prioritizing patient and family needs and well-beings over policy and inviting the birthing person to lead the conversations. So we have thought of, we recentered the patient in all of this work as being the driving force behind it and the beneficiary of it. Um, and so, yeah, these are just a couple of the bullets that speak to those specific things in the patient safety bundle that we utilized. Next slide. So we started with, this has been over a year plus work to get to where we're at. And we want to share today where we currently stand, where we are going with the family care plan, and to seek your help in promoting this initiative. So this is our logo that we are using as a visual indicator of this work. Next slide, please. So just to level set, what is a family care plan? So it's a care planning document that aims to support pregnant people in consolidating their medical, community, and social supports throughout pregnancy and the postpartum period. Pregnant patients with substance use in pregnancy is the primary population, but the Vermont specific tool that we created is meant to be used universally as a care planning tool for all pregnant patients. So some of our regions that we've been speaking to care plan on all their patients already, and they're going to continue care planning on all their patients and utilize this new tool. Where other regions are based on capacity and current structure, will start with the substance use population, but hopefully grow over time as the tool becomes more implemented within their workflows. So during our pilots, which we'll talk a little bit more about, we'll see a range of use of this care planning tool, but it is universal and can be used for any pregnant patient in Vermont. Next slide, please.
Hi, so some of the highlights are that this care planning will start early in pregnancy. So that's a shift in time to allow for better wrapping around of services. It's going to be on a virtual platform that is HIPAA compliant, very secure. That pregnant person who's filling out the family care plan with their support person will decide who they get to share that with. So putting some of that control back in the hands of the family to decide who they're disclosing to. It's creating earlier connections with community partners, including Strong Families Vermont, the home health nursing program, as well as a variety of other partners who can all be included on one document for supports. And then providing pregnant patients and families with as many resources early on to prepare for parenting. And also we are really focused on making sure we're also including supports and being mindful of situations where a parent might not go home with their baby at birth, and just making sure that it still continues to be a supportive document for them. Next slide, please. So this is just a little bit about the highlights of starting that prenatal family care plan. So we're looking to decrease stigma. So especially if we see it utilized among patients more generally, that will, I think, help decrease stigma, but even having just frank, honest conversations early on, increasing that care team coordination. We are really hoping to decrease surprise at the birth hospitalization for the birth. So both with the parents and with staff supporting them, making sure that everybody is well prepared. It's more clarity and less repetition for staff. So if we can do that care planning early on, it's a less of a lift for those inpatient care coordinators. Generalizable across settings, so it can be used by multiple partners and multiple clinical spaces as well. And starting it early on really allows for more time for connection and building trusting relationships. And for that follow-up piece, it allows the obstetrical office or whoever's starting that care plan to re-offer services at different points too, to make sure that that's happening. And then it really empowers the family to be able to decide who they're sharing their information with. Next slide. So the revision timeline here, we're looking at right now, we're in the period of creating the directory for the e-form, which we'll go into later, but making it something that people can select from a directory to send them to. We are concluding or have concluded the feedback sessions with partners and implemented all the edits that we received on the family care plan. I'm sure we'll be doing more as we go along as well, but we've done a lot already. And then right now we're looking at the pilot sites, and we are hoping that we can get a variety of methods that it is initiated and shared. So we have a couple of sites who are interested in starting at the obstetrical office, and then with a home health referral as well. So we're kind of looking, how does it look when an obstetrical office holds it themselves? How does it look like when they refer to the home health agency? And then we had one region who was interested in understanding what it might look like for MOUD hub to initiate that family care plan. And then, of course, we'll be making edits to the form and the system and the educational materials over time as we implement use of it. And then we're hoping in this fall, early winter, to see that spread to all of the different regions. And we have our perinatal quality collaborative partners helping with that quality improvement assistance and making sure that that rollout is well supported. Next slide.
Okay, so we're not going to get real deep into the weeds today, but we want to give an overarching for those of you who may have been hearing this for the first time, like how does this all work? So we've created a couple of algorithms to help like differentiate how this process would get initiated. So the big picture is that there's initial screening during the first trimester. And when we surveyed our OB clinics across the state, 90+% of clinics were screening at some point during pregnancy, and most often in the one of the first initial appointments for substance use disorder, with either a paper screener or a conversation with a provider. So while there's always advances we can make in our screening practices, we at least we're starting at a good point where the questions are being asked. So if you follow down on the right, so if there's a positive screen for substance use during a prenatal visit, the OB or family medicine office who is doing the prenatal care would make a referral if that's their pathway, or send a notification to someone within their own office who is initiating that family care plan. So then we have our three different buckets of pathways that could initiate the family care plan. One would be a referral to home health, and they'd be set up with Strong Families Vermont in their region, and that team would initiate the family care plan. And the purple box would be they have somebody already established in their office who is care planning with patients, and they would hold that role through this revision and would initiate the family care plan. And then, as Katie spoke to, is some regions have identified really great connections with their MOUD clinic. So those who are getting MOUD services, which we know are not everybody, um, could initiate it through that pathway as well. Um, so whoever is deemed to start that with the patient would connect with them and would physically sit down with the patient or virtually and fill out the initial part of the family care plan. And during that, the patient would decide who else they would like to share this with. So I want to share it back with my OB provider. I want to share it with my mental health clinician. I want to share it with my MOUD provider, with my home health nurse. And they'd get to designate who they would share it with, and then that person would receive a copy after the patient has completed that initial section and signed saying, yes, I agree, this is my information, and this is the people I would like to share it with. Um, each office who would then receive one would have their internal process of who's receiving it, either via fax or secure email, and how they would then upload it into the patient's chart so that care planning tool was accessible for those who are part of the team. We encourage updating it at a certain interval. Here we put 32 weeks because that's what we receive from feedback from some of the OB offices, that there's already some other updates or screeners happening at 32 weeks, so it would be a good fit there, but it doesn't have to be at that exact time frame. But the update one is a lot quicker process. It's asking a few questions about preparation for the hospital and if you've chosen where you intend to birth. And that would allow you to check either yes or no for sharing your care plan with the inpatient team. So again, no surprises. Everyone's on the same page. And that's part of the directory that Katie was speaking to. We're trying to build in those endpoints for all of our types of offices. So when a patient says, I'm going to deliver at CVMC, they click on CVMC, and on the back end, it connects to that secure fax or email. So no one's looking at fax numbers or emails or expecting that from the person, the birth person, or the person completing it with them. And that would also include our pediatric colleagues as well for the endpoint. So then they get admitted to the hospital for birth, and then each team is deciding who would help complete this. And again, it's a few questions. The bulk of the care planning is already done. It's revisiting some of the referrals that maybe the family wasn't interested in to begin with, but now they are, now that the baby's born, and just kind of like tying up any loose ends. And then identifying the pediatric provider to also receive a copy of this family care plan to then follow into the pediatric space. And then in the algorithm, we have a reminder that after the family care plan is completed, then the CAPTA would then also be completed. But two different links, two different systems, but as a kind of a reminder, we built it into this algorithm. So we'll go to the next slide. So that's kind of like was the overarching. And then for the pregnancy provider, we also gave this as a resource as to like when to initiate based on the type of substance use reported. The left-hand side looks at cannabis, alcohol, prescribed benzos, and prescribed opioids. So those would go into a different pathway of counseling on the effects of on pregnancy and the fetus, offering resources, offering alternatives for symptom management, and then really looking at a rescreen. If there's continued use after, education and counseling, then this might be indicative of a use disorder. So, and the family needing more supports. So then the initiation of the family care plan would happen then, versus on the right side for any of those substances on the right, those are kind of like automatic, like let's wrap around services as quickly as possible. And then the rest of the algorithm is the same. But one thing we want to note is that we did build this, as I said, universally. So this is really specific to the SUD population, but at any point, a family care plan can be initiated with families. And if the patient arrives to the birthing facility and hadn't had prenatal care or recently moved and didn't have one, the system's built so an entire care plan can be initiated and completed at time of hospital admission if one hadn't been started prior. So it's an easy access. Try to make it as low barrier as possible for ease of use. And then next slide, please. So this is a QR code, and this will be a clickable link when you receive the slides of what the family care plan template is online. This is a snapshot of what the initial screen looks like. We have built in a leading question that says, like, are you utilizing this care planning tool for, and choose one, and one says for training, and then one says for use of care planning with a Vermonter. So you can go in and look at what this is, and we use it, to teach new regions how to utilize the family care plan, putting in fictitious information. It's a way we've been testing the system to make sure all the technology is correct. So you are welcome to go in and check it out. Next slide, please. Yeah, so this is, I just did a couple screenshots of what the questions look like. They're broken up into different screens to make it palatable and to make it user-friendly on a laptop, on a tablet, on a cell phone. So they're broken up and there is branching logic. So for some things, you don't have to fill in to move on. And anything in red asterisk, you do have to, it is a required field. Oh, excuse me. We tried to keep the required fields to a minimum to not have any barriers, but we are also looking at that during the pilot as, do we need to change any of the IT logic behind this? And we also did branching. So if you fill out in a certain way, you don't see any excess questions that don't pertain to that person to try to make it as efficient as possible. Go ahead, Sam, if you want to click to the next one. So these first two just look at different types of providers and what those sections look like. And then the third one is a section on different supports around referrals, such as WIC and SNAP and Reach Up. So that's just a snapshot of what some of the screens look like. And then we'll go to the next slide, please. So at the end, after a birthing person fills this out, it will generate into a PDF, and they'll receive a link via email or cell phone to be able to review their information and then initial and sign it. So this goes through like a DocuSign process, like similar to how you would like sign for a mortgage or other type of um, secure document. And this is just a snippet of what it could look like. This is one of our earlier versions, so we've made some edits since then, but this would be the structure of the downloadable PDF that the patient would receive as a finished copy of that first step, and or providers would receive the same exact looking thing as the care planning tool. And then next slide. So what happens after discharge? So the infant's PCB office should help follow up on any new referrals made for the infant. So we're trying to close that loop and not have it in 5 different places in the chart. So really trying to like narrow it down into this one care planning tool. So it's easy for anybody assisting this patient to see, oh, WIC's already been enrolled, or this is still home health. They discussed, but they declined at the time. Maybe that's something I can revisit. And then also giving the family like ownership in the sense of, okay, these are the things that we talked about. We know how tired our families are, especially in those first couple days postpartum. So this also gives everything kind of in a succinct package for them to be able to go through and be like, oh yeah, I did sign up for that and I did do that already, or this is still in limbo. So the next slide, I have Michelle talk about the integration.
Yeah, so I think one of the things that I would love to see, and I hope that we continue to push forward, is really moving forward. As we know, families are really wrapped in their prenatal care, and then hopefully we're bridging some of these community resources to help us make that jump from pregnancy and all the visits they have to the birth of the infant and all the visits they have in the pediatric medical home. And so there is that role transmission. We know it happens, and we know that people can, fall off or get lost to follow up. So closing that loop to allow us to know, were there new referrals placed during the birth hospitalization? What things have already been done? What things haven't been done? How can we help families really be successful in that first year of parenting? That also allows us to care coordinate. Not all of us have embedded care coordinators, but if we can look at a document and know that the family has been engaged in multiple services, we can take a look at that and just make sure that there aren't any other needs that aren't being met. So one of the things that I've been pushing for a very long time is really to introduce the idea of the pre-birth pediatric visit or prenatal chat to all families early on, or recommending it, in the late second, early third trimester, so that people have an idea of where they're going. They can go and ask questions. They can make sure it's a good fit. And then that will help, as you go through the family care plan, there's a nice part in here about, have you basically chosen a provider for the baby, and who is it? And do you want to share this information to the office? Which is a wonderful way to kind of close that loop. Next slide. So this is like one of my favorite slides, and I recycle it and I change it, but this is a point where I can really feel like, as we've moved forward over the last 7 years, that we're moving much closer to the family care plan, really serving as that one tool that helps connect The birthing parent with their prenatal providers, including their substance use providers, with all the community supports and home visiting supports through that birth hospitalization and out into the pediatric medical home. And hopefully the family is also supported in their medical home as well. But just really knowing that this is the idea that the family care plan will be a family centered, owned by the birth person, but really utilized to help make this transition over what could be a lot of silos in the medical world. Next slide.
And one thing I want to add that I realized I forgot too is, I think Michelle spoke to it, is um we also, while the original like legislation was focused on like the newborn had a care planning tool wrapped around them, we really kind of widened it and brought it back to starting with the birthing parent and hopefully following the birthing parent. So we reference having a PCP in this family care plan because we know so many of our birthing parents don't have an established PCP, and pregnancy is a time that maybe we can try to connect them to a PCP. So we're not dropping off care once OB services are no longer being engaged with in the postpartum realm. We know from our MMRP data that we're losing Vermonters in that postpartum period. So we've been really mindful in this whole process of wrapping not only the whole family, but the birthing parent as well, who may or may not parent afterwards. So we were very cognizant of our language. So any of the preparation for the newborn coming home, we were mindful in that language and gave people like the option to skip those questions if they do not plan on parenting, because we do hope this follows the birthing parent as well, as the services hopefully will continue for them in their medical and recovery journey. So I just want to highlight that because I think it's really important that um, we acknowledge that not all birthing people will go home parenting their newborn. So we want to be mindful of both patients in this couplet care model. So next steps, we'll um, as Katie mentioned, we are piloting and we are really close to getting this off the ground in a couple of our sites. So this is a collaboration between inpatient, outpatient clinic, home health agency. So while we just listed like the physical locations of birth, this is not representative of all the players that will be involved in the pilot. So I really want to call out all the different partners in this work. But the three sites currently that we're looking at are Northwestern Medical Center and their inpatient, outpatient teams, Central Vermont Medical Center, and then UVM Medical Center in the high risk clinic that would broaden a little bit to any high risk patients who might need some care planning and not specific to SUD to be able to learn from that experience as well to utilize this tool. So as you can see, that's just a snippet on the right of making sure we're connecting to the inpatient teams and what the questions would look like for families, with the hospital being a drop-down selection. And then next slide, please. Um, we will be providing support with teams walking hand in hand in this experience. We plan on piloting at least at three different sites as we showed, but open to others if they're interested in getting this up and going. We meet one-on-one with the teams and, map out the workflows and like what still needs to be figured out before we're ready to go live. We are providing any of the education needed and materials for provider, staff, and patient-facing materials. So handouts, videos, so things to explain like what is the family care plan, how do I engage with it. So that's currently, we're finishing up those products to be ready for the pilot. And then really utilizing the pilot to figure out what are the things we didn't think of. We know we didn't think of everything. We've been discussing this for a year and a half, 2 years now, and for this revision, and we're at the point where we just need to kind of get it out there and see what we get for feedback and see what happens, and really trying to utilize experience of the patient and those helping them fill it out to guide any revisions that need to be made at this point. We've had some of our patient and family advisors look at the form, but it's very different, like reviewing a form versus like being in the moment and filling it out as a birthing person. So we're going to make sure we have lived experience voices in this next round of revisions. And then next slide. All right. Was this still me, Katie, or is this you? This was me, I think. So consider being a pilot site. This is our email inbox specific to this process, trying to, keep everything as tidy as possible. But you're always welcome to reach out to any of us and we'll get you pointed in the right direction. But we are happy to discuss with any other site who's interested in implementing during the pilot section. And then if you're not ready to pilot, but you want to learn more, consider how can this be integrated in your practice and start having those conversations. What we found out with some of our sites that we've been speaking to early, like this was a time for them to re-engage other partners and figure out their workflows and maybe adjust their workflows. And that takes time and conversation. So it's great to get those conversations started, even if you're not going to be one of our pilot sites. Explore what you have for resources in your community already. Join our directory, which will be our next slide. And then we always want to push back to Vermont HelpLink as being a really great resource for any substance use specific um, resources in Vermont, specific to Vermont. If we go to the next slide. This will also be in the slides, but we are really trying to build this directory. Like that's what's going to make it all the dots connect. So we've gotten a decent start, but we still have a long way to go. So we need all pediatric provider practices to identify how would they like to receive a family care plan. And your options are secure fax or email. We need all inpatient birthing and postpartum units to do the same thing. All the OB clinics, all family medicine that care for pregnant patients or newborns, mental health providers if they want to be listed, and then our MOUD providers and substance use providers. So this QR code works, or when you get the slides, this is a clickable link and it's like just a few questions. Who are you? How do you want to be notified? Who's your point person? Really simple and easy, but this will allow much easier use for patients and those supporting them in initiating a family care plan if we have this on the back end. So please take a couple minutes to submit this if this pertains to you. Next slide. And then this is just a snippet of some of our materials that we are creating. So we'll have these algorithms for use for the clinics. We will have for both, all the teams, family and patient handouts for awareness. So you're not having to reinvent the wheel. We'll have some scripting around this to tie into, if your primary pathway is to connect them with a referral to Strong Families Vermont, we'll have scripting on that. And we'll have office hours and QI support all along the way. Next slide.
Okay, so this is just a slide to talk about some of the resources available. And one of the reasons that we emphasize here the nurse home visiting and the recovery partners of Vermont, because they're statewide resources. So we know every region has access to those supports. And with the nurse home visiting program, we really emphasize them as partners because they can support a family throughout that full postpartum period. And they also have that clinical expertise for assessment and feeding support and things like that, because sometimes newborns with substance use exposure can be have their own sort of clinical needs and things like that. So we really want that to be a primary support. And then the recovery partners, they have recovery coaches who are trained to support people with substance use. So we really know those resources are available everywhere. We also want to direct people to this bidirectional learning for improved support and services, which is a perinatal substance use curriculum. It's free and available to anybody on the PQC website, and it has different training modules to support people enhancing their understanding of either perinatal kind of health or substance use topics, kind of depending on where you're coming from. That's designed to help everybody kind of be on a level set playing field there. And then just emphasizing this Recovering Loudly project, which is stories of perinatal substance use from people with lived experience. And it's an amazing set of videos, but it also is kind of addressing that stigma piece and kind of helping people to understand the lived experience perspectives. And these are resources, like I said, just a few resources. Every community has a different set of partners and resources that they can access. So we're not saying these are the only ones. We're just saying these are a couple ones we know are statewide and particularly important, but there are lots of community partners wanting to engage and support families. Next slide, please. This is an upcoming webinar in a couple weeks on June 16th, and it's looking at the Vermont mandated reporting guide for perinatal substance use in particular. Caleb Pinko has worked really hard on this, but we've also gotten input and feedback from a variety of partners, including really working intensively with our Family Services Division partners. So this is really looking at what is required of a mandated reporter in the clinical spaces from that perspective. And when, what are you required to do before the infant's born versus, a live infant in the situation. And we'll go into a lot more detail on that, but that is coming up in a couple weeks. Next slide, please. And this is our last slide. We're going to open it up for any kind of questions or conversation for the last 15 minutes, but this is the email address you can use to ask questions and reach out for follow-up if you want to. So that is it for our slides. And now we are interested to hear if anybody has any questions or thoughts they want to share. Look at the chat here. I think it's mostly resources being offered. Yeah, feel free to unmute or put something in the chat if you just, what are your initial responses? Recording of the session be available to share with other team members? Yes, we are hoping that this recording will be used to in the future as well as we're pulling sites in for using the family care plan and all that kind of stuff. So this will be on the Perinatal Quality Collaborative website. Yeah, and the slides as well will be available. And the slides have embedded links throughout them. So the resources that we talk about, you can click those links as well.
And for the nursing leaders on the call, I do plan on having a quick like module, for lack of a better word, to explain this. So because we know not all people will have direct utilization of this. Like some of the inpatient teams have case management or a certain person who will be doing the ins and outs of it. But so I'll have something for more broader awareness for nursing staff or others for pediatric providers and just a more of a baseline for awareness too, because we just know it. People be like, "What is that?" Or "It used to be called this," and just teams are reorganizing themselves. So we'll have it in various ways for you to share with staff and providers.
The other thing too, I think that when your region is considering implementing the family care plan, bringing it to groups that are existing like the CHARM teams or the community response teams, thinking about that full community spectrum or your regional perinatal quality collaborative, those are also spaces to think about how you might use this to connect the clinical and community spaces as well.
And with that said too, like this, there's a lot of future possibilities with this structure. We're kind of, starting, we started hopefully from a good spot. We utilized some work that had been done at UVM by the case management team on making it a little bit more well-rounded with looking at social drivers of health and all, other things. So we're really excited to start here, but we know that there's options to go a little bit deeper into connections or community resources. So we try to keep it to either services or things that were pretty universal across the state, knowing how each region is very different. But that's not to say that if there's, strong feedback on like, oh, it'd be great to have this listed, like we are open to um, those potential revisions and additions in the future. We just want to kind of get it going and see what Vermonters think and see what our providers who get to help get these started think before we get too far into the weeds.
Oh, one other thing, again, to emphasize that I'm not sure if Kayla covered, but with the family care plan, we're going to have an option when you log on to the virtual site for training purposes or live use. So just making note of that, making sure you're selecting the right version so we don't get data that's not correct in there.
And as kind of the old lady on this, who's been doing this for a long time, I also want to just highlight how exciting it is to move away from, that piece of paper that just felt like another have to at hospital discharge to something that hopefully is really something that we intended. And Ann Johnston, I think, would agree with us as the person who really got this kicked off, that this is a process that is meant to completely decouple away from the Department of Children and Families. Not that we don't appreciate their assistance and we need them in some cases, but this really helps to move away from a punitive and really looking at how can we support families, how can we help them early in pregnancy to get the resources they need so that they can have a healthy pregnancy and a safer, healthier postpartum journey. And then how do we make this easier for us over in the pediatric field to really address and talk to people about and demystify a little bit that understanding and that transition. And yes. So the online forum discussed today is currently in the piloting form, and not yet available for use everywhere. Once it is available for use everywhere, we will make sure we let everyone know. In the interim, you can continue to use the older document form, which still says Plan of Safe Care on it. CAPTA notifications, however, should be made through the electronic version, hopefully. And, again, the CAPTA notification being something that is used entirely just for aggregate data reporting to keep us in compliance and to make sure the state receives the federal funding it needs to address all types of family supports and child abuse and neglect mitigation. So that form is really important. And right now, yes, we're kind of in that crossover phase where there will still be paper forms, Plan of Safe Care paper forms, while we continue to, make this live for all places to use. Now, you certainly can go and try it and see what you think. But as the database continues to be developed, it will allow a lot more real-time sharing of information. And I think one thing we didn't mention, and Kayla can speak more to this, but this data will not be out there forever. It is certainly we are very sensitive to the nature of this information. And so again, families will own that PDF of their information. And then depending on who they choose to share it with, each provider will get a different subset of information. So there's certainly information as a pediatrician that I don't need to see, but would be relevant for the family as they continue to look at how to best organize the services they're engaged in. And so I think that's also a wonderful part of this, where we can allow the family to have a much more complete, detailed copy of something. And then those people who are engaged either in the perinatal or prenatal spaces or pediatric spaces, we may see a different version of the family care plan. So certainly much more flexible and protects the privacy of the parent. I think the last thing I wanted to add is that, we are going to encourage families to share this information, but at the end of the day, the family care plan is theirs. And it's not a have to. It doesn't have to come to me as the pediatrician. Ideally, understanding that the information shared is mainly to help support the family and make sure that their needs are met is paramount, but also because a family doesn't feel comfortable sharing does not in any way mean that there's a problem or they shouldn't be forced to share information. So this is a different situation than previously with the Plan of Safe Care, where it was just automatically scanned into an infant's record. This again gives agency back to the family. And again, I just want to make sure everybody is aware that the 2021 reauthorization very much supports that. And so we actually are going to be in compliance with federal law by not requiring it to be scanned into the infant's chart or the mother's chart. So that's just another important
And
distinction.
just and to go back to the question in the chat about using the online form, if your hospital or clinic or wherever you're from are interested in being a pilot site, that's great. And we really want to encourage people to engage in the piloting process and or the supportive sort of quality improvement process, because it's going to require planning out workflows across different spaces and being really thoughtful about integrating it. So we just want it to be as successful as possible for different sites, and learn as much as we can about the best ways to approach that. So certainly welcome if you want to engage in the piloting process. So go ahead and reach out if you want to do that. But we do encourage you to hold off if you're not quite ready to pilot yet until we can get that going. Any lessons learned while developing this type of embedded multi-partner tool? Yeah, I think we've learned a lot of lessons already about who to pull into conversations and getting feedback and pieces like that. I'm not quite sure if somebody wants to unmute and ask a little more specifically what they're looking for, or if Michelle or Kayla have thoughts about that.
Well, I say we did learn a lot, and I will say this is like the culmination of multiple quality improvement projects and other projects and huge like American Academy of Pediatric learning collaboratives and IDTA work. So this is like the culmination of multiple projects that have been going on like since 2021. And we certainly have learned a lot of lessons. One of them is, we learned from other states who had started this first, some lessons about how to move forward, and the best way to do a form that would be available to multiple different agencies, and how to make sure that we were really supporting collaboration while protecting privacy is really important. And then definitely bringing the people on the ground in, right? So you need to know what's actually happening when a care manager or a bedside nurse or, whoever was doing the previous care processes, like what are you doing in what roles, right? So perhaps at your hospital, you're doing a full health-related social needs or social drivers of health. Maybe you're having a care manager or social worker seeing every patient. Like, how can we not duplicate workflows while addressing the things that we know are impacting our families, right? So not just asking about substance use, not just asking about who's your MOUD provider, but really getting into like what other things do you need. Some of the questions on the family care plan go into things as simply as, do you have a car seat? Do you have a crib? So as you get into that further down the line, when you're updating and you're looking at planning to go home, those kinds of things are in there. So I think it's really about like bringing together people, not just at the top of the, thought process ladder, but also the people that are doing the work on the ground from all the different partners and stakeholders. So yeah, it's definitely been a big process. And it takes a long time. That's the other thing to learn. It takes a long time to do this.
And just noting too, Sam put the link for the evaluation. We really appreciate feedback on these webinars. So please take the evaluation.
And we see it's 1 o'clock. So thank you, everyone. Please feel free to reach out via email, via the listserv, do the evaluation, and we hope to see you in a couple weeks for the next webinar.
Thank you all.